Okay, we are officially recording. This will be the class Zoom session to discuss through the Susie Phillips video case study. So what I'm going to do is go ahead and share my screen. And basically, I'm just going to pull up the accompanying worksheet that went along with that. And I want to talk through some various concepts related to Susie's case in particular. As always, the group chat is available over on the side. So please go ahead and put your, put any questions you have in there, and I can address them kind of as we go. But I really liked Susie's case in particular because it really hit a lot of the different concepts that we had talked about, those basic, the basic underlying concepts of, care of the cancer patient. So let me go ahead and share my screen and we will get started here. Okay, so everybody should be able to see the accompanying worksheets. So we'll just kind of start from the top and, work through and thinking about the concepts. So with Susie's case, and obviously her particular diagnosis was, it was a breast cancer. So with her age, she didn't fit the typical breast cancer patient. Typically we think, definitely above 40, certainly usually we see it, in the late 50s, 60s when it's developing. But in her particular case, she had had some issues with her breasts earlier on that were non-cancer related. So for her, she was more in tune to what was going on in her breast. She had had mammograms before. That really is not typically the norm. When we think about screening mammograms, typically they're starting at age 40. And she was well underneath that particular, benchmark when this occurred. But what was very interesting is she had noticed the lump herself, and basically, based on her history, had kind of dismissed it, even though it was a little bit different than what she had experienced before, but she was able to kind of rationalize that away. And, that kind of speaks a little bit to human nature in the sense that, we always want to think, kind of put the worst case scenario off to the side. No, it couldn't be that, not me, that sort of thing. So when we think about health promotion and we talk about breast self-exams, it really is important that we talk to patients about that. They really should be performing breast self-exams monthly. We talked a little bit about this in the last Zoom session, but they want to try to stay consistent with the time of the month in relation to their cycle, because there are breast changes that occur with ovulation and menstruation. So we don't want to have them, feeling different things at different times of the month and thinking that there's something different. So it's very important that they stay consistent with their timing. But this really is a good self-examination. It also gets the person in tune to what their breast typically feels like. We think about a clinical breast exam that's done with the annual physical. That's once a year. And yes, those providers are trained to find things that are abnormal. But if a person is doing their breast self-exam monthly, they can often pick up on changes that may go unchecked. Okay, so that's pretty important. So in the video, when Susie talks about discovering the lump in her breast, and she talks about, the sizing, the pea size, and then, by the time she got in with her provider and they checked it, it had already increased in size. At that time, she was still kind of dismissing it. The initial provider, who was a non-cancer specialist based on Susie's history, also wasn't very concerned, but did advise her to go and have a follow-up. And the time between that appointment and the follow-up really wasn't that long when you think about it. And the lump had already increased in size even more. So when you think about the increasing of that growth, it kind of goes back to the concepts that we were talking about with staging and grading. So the larger the tumor is, the larger the primary tumor is, the bigger the number they're going to get on that TNM nonogram that we use. Okay, so certainly the larger that the tumor is, the more likely we're concerned about spread. We're concerned about regional spread. We're concerned about it pushing on, regional organs. In Susie's case, where it was in her right breast, it was very close to her sternum, to her rib cage, and eventually it did become affixed to that. So when you think about that, her particular cancer was very aggressive in the growth. Okay, so that's not necessarily typical of breast cancers. A lot of times they are slower growing in the sense that it's pretty significant by the time they get diagnosed with it. But hers, because of the actual underlying tissue that it was, so she ended up with a sarcoma. Actually, it was a combination, but the piece of the sarcomas, they do tend to grow a little bit faster. So hers, when you looked at the pathological piece underneath the microscope, when they actually did the true tissue testing after her surgery, that's where she kind of had, the very odd diagnosis. But when you think about the growth of her lump, what I want you to really understand with that is it was progressing very quickly. If you go back and look in the video, we're talking a matter of weeks from when she discovered it until she saw, her initial primary care provider, till she initially saw, the GYN person, and just really, it grew significantly. So that lump growth really related to her prognosis because the cancer was progressing rapidly. It didn't necessarily spread outside of that tumor because the tumor ended up being encapsulated, but it grew very rapidly. So when she was initially diagnosed, and we talk about her staging, and they talk about her visit down in the office, when they did the core biopsy, and he basically told her, I need to wait for the results to tell you for sure, but in my years of experience, this is cancer. I just need to be able to look at it under the microscope, get the biopsy so I know what kind. But that was pretty significant. And when her results came back, they talked about it being triple negative. This is a breast cancer, so it's a reproductive cancer. It can be influenced by hormones. So that's really what we're talking about here. So your reproductive cancers can be fed, so to speak, by certain hormones. Now we have estrogen, you have progesterone, you have the testosterone, you look at that sort of thing. So what they do when they do this testing, and as part of the biopsy and they do the testing, but for your reproductive cancers, they look to see if they are hormone receptor positive or if they're hormone receptor negative. Now this really applies just to your reproductive cancers. But if your cancer, if it's a reproductive cancer and it's hormone receptor positive, that means that the cancer growth is influenced by hormones. So in a way, that's good because we know what's feeding the cancer. And depending on what hormone we're talking about, we can give medications that are very specific. We're essentially blocking that hormone, and you're essentially cutting off the food for the cancer cell, and it won't be able to grow. So that is very helpful when we talk about follow-up care. Generally, if you have a solid tumor, the first thought is going to be for surgical removal. However, in Susie's case, because of the size of her tumor and the location of that tumor in relation to her ribs and her chest wall, they chose to do the chemotherapy first in an effort to try to shrink that tumor so it would be easier to cut out when they did the surgery. You can also see that done, sometimes they'll use radiation prior to surgery for the sole purpose of really trying to shrink the tumor so it's easier to do the surgery and get clean margins and try to save the additional tissue. But ultimately, if it's a solid tumor and we're looking at, cure or control, it's not spread to the point that we're looking at palliative care, the goal is going to be to get that solid tumor out. Okay, so for Susie, that triple negative piece was difficult because they didn't know what was feeding her cancer. So, they were going with some traditional standard chemotherapy cocktails for her, but you know, those were not statistically as successful as they would be if we had a hormone receptor positive that we could treat with a specific drug to block that hormone. Okay, so with Susie's triple negative cancer, that really made it difficult, you know, to try to customize and really tailor the chemotherapy treatment to her. They're basically just going with what was standard and seeing how she was going to respond to it. So for her, she did have, it was a standard chemotherapy cocktail for your breast cancer patients. This is very typical for your triple negative breast cancers. But she had adriamycin, Cytoxan, and Taxol. So that is a pretty standard protocol. Adriamycin, the generic name for that is doxorubicin. So if you've taken the ATI custom practice assessment already, you'll notice there was a question in there that had doxorubicin. The reason I like to point that one out, we talked about common side effects of chemotherapy. Adriamycin also has an additional piece to it. It is known to be cardiotoxic. So it actually is known to cause damage to the heart muscle, to the myocardium. And long term, it may not even show up during the actual treatment. It can show up years down the road. So patients that are treated with doxorubicin, adriamycin, they are followed up with a cardiologist. They get periodic echocardiograms, you know, just to kind of monitor that. Now, again, you're like, okay, well, why would we give this drug if it's going to hurt their heart? Well, at that point, the cancer was killing her faster than a cardiac problem would have. So anytime we give a medication, and it includes chemotherapy, we look at the benefit at the time versus the risk to the patient. And, you know, I think she described it in the video that she said, you know, sometimes we take you literally to the brink of death in the hopes that we're going to be able to save your life. And that really is what it is. I mean, chemotherapy is a toxin. It is designed to kill cells. Now, we want it to kill the cancer cells, but the reality is it affects the healthy cells too. And that's why you see the side effects that are associated with the chemotherapy. So with Susie, because of the size of her tumor, they had her on what they call a dose-dense treatment. So the particular ACT protocol cocktail that she gets, usually that is going to be administered every 3 weeks, okay? Because we're essentially causing an assault on your body, and it takes about 3 weeks or so for a typical person to be able to recover enough to be able to tolerate the next treatment. Given the size of her tumor, her doctors were very uncomfortable with that 3 weeks. They really felt, we need to shrink this tumor, we need to shrink it now, and they dosed her every 2 weeks. Now, I just want you to stop for a minute and think about the significance of that. We talked about pancytopenia, okay, the decrease in the blood cells in relation to chemotherapy because it's affecting the bone marrow. If you think about the general life cycle of a white blood cell, it's 10 to 14 days, okay? So with the regular regimen, the every 3 week regimen, they would get chemotherapy today. About 2 weeks from now would be their lowest white blood cell count, and they would have that additional week to have it start building up before they get their next chemo treatment. With Susie, we backed that up. So she was literally scheduled to get her next chemo treatment at the time when her nadir was hitting, her lowest point of her white blood cells. So that dose-dense form, you know, we're giving the toxins more close together, and she doesn't have the time to really be recovering before that next treatment. So that made things very challenging for her. It also put her at extremely high risk for contracting infection. And when you have somebody whose immune system is just down to this point, I mean, literally a common cold can kill them, but they can move very quickly from a beginning infection to sepsis and into septic shock, which then can lead to death. So this was a huge thing for her. You heard her talk in the video about once she started, you know, treatment, she was essentially, you know, quarantined, homebound. that she wasn't going anywhere, because really the risk of her going out, the risk of exposure to potential infections would have proved deadly to her. So this was a very difficult time for her during the chemotherapy piece. And she experienced, almost all of the side effects that we talked about. She had the severe nausea and the vomiting. And she mentioned in the video, and I believe I had this in the comments on Play-Doh, and this is an example of how things have changed. Her treatment was in 2010. So, you're talking 10 years ago. But initially, they did not always pre-medicate the patient for that first visit. They wanted to kind of see how the body was going to react. That's changed. I mean, we know that this is going to happen to a majority of people. So we have gone ahead and started pre-medicating these people, and using things like ondansetron, Zofran, is a very powerful antiemetic. And I'm not talking the dosing that we typically give in the hospital, okay? We're usually giving 4 milligrams, 8 milligrams of Zofran in the hospital. A pre-chemo dose of Zofran is usually about 24 milligrams that they're putting into the patient before chemotherapy. And then, of course, following up around the clock with Zofran, ondansetron. And then in Susie's particular case, she was also on promethazine or Phenergan, which also helped with the nausea, but that also has some significant sedating side effects as well. But she was literally, they kept antiemetics in her system pretty much around the clock. Susie talked about her IV access, and she actually had a port. And we talked a little bit about that in our last Zoom session, that it was very nice because that port is covered by the skin, with the exception of when she is receiving chemotherapy or getting labs drawn. Literally, it's covered by the skin. They do access it with that special Huber needle. It's still considered a sterile procedure when you're accessing it. It's still a central line. When you're infusing things into it and cleaning things and flushing. So we follow that central line protocol. But when it's not accessed, it is protected by her skin, which makes it very beneficial. We talked about how chemotherapy medications are vesicants. They're very caustic on the vessels. So it is not ideal to be giving chemotherapy through peripheral IV access. It's just not. So that's why ports are very nice. In some cases, they can't do ports. They'll use other types of central lines, subclavians. They'll put midlines in. But ideally, the port is really the way to go with this, mainly because they can be used for a long period of time. We've had patients where they've had cancer and they finished their chemo 5-6 years ago. They don't go and take the port out. They'll keep that port in. Now, there is monthly care to the port. It really should be accessed each month, flushed each month with heparin just to keep it functioning, but they can stay in for years. And it's very helpful to these patients because they're not constantly getting stuck, because we can draw blood off of them. But it's very effective for the delivery of chemotherapy, as well as fluids that go along with chemotherapy. Susie talked about her regimen, and she got her pre-medications. She had some Benadryl. Sometimes they give her Tylenol, definitely the Zofran. But a lot of times they will give fluids before and after chemotherapy, mainly to keep the patient hydrated. We certainly want to support circulating volume in case they have a reaction where their blood pressure drops, but also to help keep the kidneys hydrated, because these toxins that we're putting into them, from the chemotherapy, they do affect the liver, they do affect the kidneys. And, we always worry about that, end organ damage as a side effect. So it is always very important to watch the liver function studies, to watch the BUN, the creatinine, and the GFR, and really try to prevent those problems by maintaining hydration. And of course, watching them, if all of a sudden they have a decrease in their output, well, what's going on here? Are we starting to see some toxic effects of the chemo? Okay. Come in here. All right. So looking at Susie's typical routine, and I kind of talked a little bit about this at first, but You know, she would go in, she was there for several hours. You know, they would access her port, they would draw her labs. That lab piece is very important because with her labs, if her numbers weren't above a certain point, and I'm not talking normal because her labs were never going to be normal, just with the effect of the chemotherapy, her white count, red count platelets were always going to be down. But if they weren't at a certain minimum number, she would not be able to receive chemotherapy because it just wasn't safe. It would knock her down to the point where the risk of her dying, you know, outweighed the benefit of giving the chemo. So typically she's going to have her labs drawn. They're going to review the labs. If she's cleared for chemotherapy, they'll go ahead and start with the pre-medication. They'll start with the hydration, and then she would get, you know, the two different medications. And the one was a drip that, you know, dripped in just like a basic IV would. The other one was one that it was a direct IV push that was given very, very slowly, but it had to be direct IV push. And, you know, she talked about that in the video, how the first time she got the adriamycin, and it's red in color, so it is often known as the red devil. But it literally, these are toxic drugs, and they have special handling protocols. The nurses that administer these, they are registered nurses, but they are also chemotherapy certified. So this requires additional training, additional education, you know, hands-on practice to actually become certified to administer chemotherapy. So this is not something you would be doing as a nurse generalist, you know, but you do need to know the basics about chemotherapy. But if this would be an area where you would choose to go into as your career, they're going to put you through an extensive orientation and training and put you through that piece to get certified to be able to do this. You know, your typical med-surg nurse, I can take care of a patient who's received chemotherapy, you know, they can kind of come back to me or whatever, but I would not be the one qualified to be able to administer the actual chemotherapy treatment. Okay, so that's very important to kind of differentiate that and know when we talk about scope of practice and delegation and things like that. You know, even though I am an RN, I am not qualified to administer chemotherapy. I am not chemo certified. So once they got her pre-medicated and hydrated, that's when they would actually administer the chemotherapy. A lot of times they'll finish up with some fluids, and then that's the end of the treatment. And again, for her, she was getting these treatments every 2 weeks. And she talked about, you know, what she would do during chemo, because they really try in the outpatient chemotherapy centers to keep it as bright and I don't want to use the word fun, but, you know, to try not to be depressing. So they use treatment chairs. They're not necessarily in a hospital bed. They're usually the treatment chairs. Of course, there's, you know, TVs there. A lot of times they can have their support person with them, you know, playing games, reading, knitting, doing some different things like that. So she talked about how, you know, she would have her chemo bag, and she had her blanket, and she had some drinks in there and some snacks, you know, and pictures of her kids. So that really, it got to be a routine for her. And she talked about how she absolutely hated it. She dreaded having to go for that treatment because she knew how horrible it made her feel, but also knew that that was the only chance that she had at life, you know, at living. And she talked a lot in the video about, you know, how this impacted her. She was a young adult female who had, you know, young kids. I mean, her oldest daughter was the tween area, the pre-tweens there, and her son was, you know, a few years younger than that. And you know, when you think about her roles, you know, you kind of step back and think about Erickson, and in the young adult phase, you know, she was married to her husband, the marriage was established, she had the children, you know, she was working, doing the ministry through her husband's, you know, ministry at the church, and how this diagnosis just literally took that family and flipped it upside down. Okay. You know, mom, her role as mom, you know, she was really out of commission. And, you know, you think about the impact of mom on children, and not that dads don't have a significant impact on children, because they do. But with the way their family functioned and their day-to-day life, that was pretty significant. And, you know, she talks about her daughter, and at that time in a girl's life, how, you know, that's an important thing. I mean, she's embarking on, you know, getting her period and going to middle school, and, you know, and kind of going through that adolescent changes, and, you know, adapting to, you know, the new social relationships and that. And it was very difficult for, you know, her daughter to not have her mom there. And it was very difficult on Susie as the mom to not be able to be there for her daughter the way she wanted to, the way she envisioned that she would have prior to this diagnosis. So, you know, that was really challenging for her. You know, Susie also described, you know, the conversation she had with her husband when they had that heart-to-heart conversation, and really talked about the possibility that she wasn't going to live through this. You know, that's a hard conversation to have, and to really, you know, have to work through that. So, you know, for her, the family support that she had, her extended family, you know, friends that she was close to through her church and the ministry, they were critical in this family's survival. I mean, certainly, you know, Susie had the physiological piece of her treatment, but supporting the family and Susie psychosocially, and just with everyday function, was key to this family, you know, making it through this. I loved at the end when she was showing the pictures, and unfortunately I wasn't there for the initial presentation, and I don't have access to the pictures that she showed to that class, but I loved how she was looking at the poster board, and she said, you know, so this was a picture of my husband and I here, and this is a picture of us a year later. So that was pretty cool, you know, to kind of circle that around. And, you know, the reality is she beat the odds. This was not generally thought to be a survivable cancer, that she, you know, that there was a real possibility that she was not going to make it through this. Obviously, I'm very glad that she did. She has had some health scares since then. The cancer has not come back. There were a couple scares where they thought it might have, and they worked her up, but she's alive today, and she's still together with her husband, and you know, doing okay, but it definitely was a challenge on the family. When you think about how, you know, the family functions, and we talk about, you know, caregiver role strain, you know, the stress that her husband must have felt, you know, obviously, you know, he wanted to protect her as much as he could. You know, she still had to go through this. You know, he could be there to support her, but she was the one going through it, and then still balancing her needs with the kids' needs. It was definitely a challenge for them. One of the things I found most profound about her case, and when she came to speak to the students, was talking about how the role of nurses in her care. You know, not that the entire team wasn't important. Obviously, everybody came together and to save this woman. But, you know, the first time when she was really talking about the nurse in the breast health center office, that she had done the exam, and the nurse knew something didn't feel right, you know, and she said, "Let me get your husband, let's bring him in here." At that point, Susie had no idea, you know, what the issue was. But she described how, you know, the husband came in, the doctor came in, and the nurse just kind of tucked in right by her side and was kind of right there. And that speaks a lot to what we do. You know, we always talk about nursing being an art and a science. And obviously it is very science-based. You all took A&P1, A&P2, micro. You know, we always talk about nursing interventions and faculty level rationale. But the art piece of it, you know, every single one of us, you know, got into this profession, at least partially because we want to help people. We want to make a difference, you know, make an impact on people. And the story, as Susie was telling her story and describing that experience and how that nurse tucked in right beside her, it wasn't so much that the nurse was saying a lot at that time, it was the physical presence. And we see this a lot with, other patients as well. There's times, especially as an inpatient nurse, you're working with patients at some of the worst times of their lives. Maybe it's not a cancer diagnosis, maybe it's a new diagnosis of diabetes, maybe it's a new diagnosis of COPD that's going to be chronic and lifelong and not going away and will likely eventually result in their death. The docs, not knocking them, it's their role. They come in, they spend very little time with the patient. It's the nurse that's there with the patient the most. And we are the ones that really have the most significant impact on how they respond emotionally to the situation. And, we talk about therapeutic communication and we talk about the techniques. I love making observations because that's always, something that you can say, observe something, and usually that's the catalyst to just have them spill. But sometimes we don't have to say a word at all. Sometimes just sitting next to that patient and holding their hand, or just, sitting there with them, your hand on their shoulder, while they cry with this new diagnosis or whatever news that they received. Sometimes it's just that physical presence that can make all the difference. But Susie talked about that. She talked about that initial experience with the nurse. She talked about the experience that she had with the nurses at the chemotherapy center, also at the radiation treatment center when she did radiation after her surgery. Okay. And how, it really built up that relationship. Being there, being the person that's sitting there, putting that wet compress on their neck or on their head. And giving them those words of encouragement. And for her, the nurses that really helped her focus on, that this is awful now, this sucks now, but you're doing this for your kids, focusing on your kids. This is why you're doing this. And really, kind of keeping her going and reaffirming the purpose of why she was doing this. Because the reality is, when they're getting this type of treatment, chemotherapy, and especially in the dose dense form that Susie was getting, that often, she was literally to the brink of death. And there were probably, she didn't say it in the video, but, there were probably times that during her experience, she may have been ready to give up. Like, I don't want to do this. I don't want to go through this. And, we all have those moments. I mean, I'm sure you've had some in nursing school. Why am I doing this? And you need that motivation, that inspiration to kind of keep you going. And for Susie, nurses really helped her through that. So that's really a huge thing that we think about. Nursing is not just the disease process and this is what we do, these are the meds we give. That art of nursing, that communication with the patient, that looking at the patient in a holistic way, not just their disease process, but really looking at, okay, yes, you have a disease process. How is it affecting you? Not just physically, how is it affecting you emotionally? How is it affecting you socially? And really working through that. And you can see, her case was a perfect example, not only to show you the physiological pieces, the diagnosis, the diagnostic testing, the biopsy, the treatments and all that, but really looking at psychosocially, how did the culture of being from North Central PA impact her overall treatment? She came from a very close-knit community, and that was a huge piece in the management of her disease process, the extended family, the extended support that she had. She has a very strong faith, and that was something that impacted her treatment and how she functioned from day to day. And people praying for her and her beliefs and how that, played a role into that. We already talked about her family, what kind of resources she needed at home. We think about this, but it's down to little simple things like, okay, if Susie did most of the cooking and she can't do that, who's taking that role on? what kind of support is there? Just transportation to and from treatments, to and from consults. At the very end of the video, she described how she went up to New York City to Sloan Kettering for a consult with a world-renowned oncologist, because she had such an odd diagnosis. Just the simple, resources to be able to do that, and, who's there to support her during chemotherapy and immediately afterwards when she needs somebody physically there with her. Again, her treatment was 10 years ago. And I know eventually at some point it'll be so outdated I won't be able to use this video case study, but for the time being, it really kind of hits all of the major areas of what we talk about for basic oncology concepts. She went through the whole thing, the chemotherapy, the surgery. I didn't spend a whole lot of time talking about the surgery in this particular unit, or surgery in general, because we've covered different aspects of other surgeries. But her particular surgery was, just so involved. I mean, the goal was to hopefully shrink the tumor prior to the surgery. That didn't happen. Unfortunately, she went through all this chemotherapy and it didn't make a dent. It just didn't even make a dent in the tumor. So when they did her surgery, it was so extensive. Just as a general rule of thumb, the longer your patient is under anesthesia during surgery, the higher risk they have for complications. And her surgery was really long because her surgeon literally, you talk about like butchering and stuff, but literally they were filleting the tissue off of her ribs to try to make sure they were getting clean margins, to the point that she actually, as a post-op complication, she suffered a collapsed lung. She had a pneumothorax that they needed to do a chest tube and reinflate that. But her surgery was very, very involved. And, we talked about in the last class how, these patients are already malnourished to begin with. So she was malnourished from the fact that she had cancer, and cancer cells tend to replicate more quickly, so they use up a lot of that energy. But also think about the effect of the chemotherapy on her body. I mean, she basically was nausea. She always had nausea. Once they got the medications on board, she wasn't vomiting as much. And they were keeping her hydrated with IV fluids and that. But her nutrition status was just totally in the toilet, even before she had the surgery. So kind of thinking about that from a surgical recovery standpoint, you're already kind of behind the 8 ball, and we're trying to make all of that up. So, her surgical recovery was very challenging as well. I mean, by that point, they had obviously removed the tumor. They did take the nodes, and that she did not have any nodes that were positive. Her tumor just got very big and stayed very localized. So from that aspect, it's a little bit different than some of the other breast cancers that you would see, because a lot of breast cancers will at least spread regionally to the lymph nodes in the axilla. That wasn't the case for her. And that's also why she kind of described herself as an odd bird. And that's one of the reasons why she saw the specialist at, Sloan Kettering up in New York, just because her specific cytology results and biopsy results were just so unusual. And that's why she required that. But I enjoy hearing Susie's story every year, because it really does hit the highlights of those key points, and it really brings it home. It's one thing to look at an interactive case study in Lpn. That's great, we can look through, but seeing it in the flesh, so to speak, and hearing it in her words and her experience really kind of drives it home and really makes these concepts, make sense. So that's kind of what I wanted to cover a little bit today. If you want to take a look in the chat box, if you guys have questions about Susie's video, anything related to oncology, we can do that. Then I will go on. I had some students email me some questions about the grade calculation, so we can talk a little bit about that. But before we go there, I just wanted to kind of hit any questions you had related to the cancer concepts. As you're preparing for the exam, keep in mind what I said about the chemotherapy drugs, okay? You are not expected to be an expert on these. I want you to look at these with the general concept. So chemotherapy, they're toxins, they're going to affect the cells. Obviously, we're trying to stop the cancer cells, but what we're really looking at is what are the common side effects of chemotherapy and what is the nursing management related to that? You know, what are the common side effects of radiation therapy and how do we manage that? So as you're preparing for the exam, please don't get bogged down into, well, this is an anti-metabolite and this is that. Look at your major concepts with that and focus on that. Okay, we got a couple things in the chat box here. Okay, can you have children after having chemotherapy radiation? Okay, so that is a great question. Yes, you can. Now, that being said, the chemotherapy does affect the eggs in the ovaries. It does affect sperm production. It does tend to affect females more than males because the sperm production, you know, happens continuously. And that is not really affected with age. Obviously, the sperm that are being produced during receiving the chemotherapy are going to be defective and that sort of thing. With the women, because technically when a female baby is born, they are born with all the eggs that they are ever going to have. They have to mature in that. So you can see some fertility issues after chemotherapy, but it is possible to, you know, get pregnant and carry a pregnancy and have a healthy delivery after receiving chemotherapy. It definitely does cut down, you know, on, you know, on the fertility aspect of it. It also increases your risk for future cancers, not the pregnancy, but just the chemotherapy and the radiation. It does put them at risk for secondary cancers later on in life. But again, we're always looking at the benefit versus the risk. Okay, so at that time, when we're treating this initial cancer, you know, fertility is not, you know, the main focus, but it is possible to have kids afterwards, okay? What does baking soda rinse do for the mouth? Okay, great question. So the baking soda rinse, what happens with chemotherapy is your patient develops what we call stomatitis, that it's just, you know, all inflamed in the mouth. They get the sores in the mouth and they're really not able to eat or drink because it's so painful and so sensitive. So the baking soda, excuse me, the baking soda itself, because the mouth tends to be more of an acidic environment because of the saliva and the digestion, the baking soda kind of helps neutralize that. So generally what we'll do with those patients is they will use a baking soda mixed in water, and they will use that to rinse their mouth several times a day. So we're trying to raise the pH of the mouth. Now, the other thing that Susie talked about was the special mouthwash that they gave her. And, you know, I forget what, I know there's lidocaine in it, there's some other things in it, but we used to call it just magic mouthwash. And it's very important because what we'll do with these patients is they will swish and spit this mouthwash. And because of the lidocaine, it numbs the inside of the mouth. And that's very helpful because it allows them to be able to eat and drink without significant discomfort. So we do this prior to each meal. Now, it's very important that they spit it out because had they swallowed it, it can also numb the swallow reflex and then they would be at higher risk for aspiration. So the purpose for using that magic mouthwash was to numb the inside of the mouth so we could try to take in more nutrition, more fluids, because the pain that they experience and the pain that Susie experienced, just it made it that she didn't want to eat, that she didn't want to drink, okay? Something else while I'm thinking about it, while we're talking about pain, Susie also developed a pretty significant neuropathy related to the chemotherapy medications. And that got to be very painful. So when they talked about how we managed her pain, because this is a chronic pain, you know, using your around the clock dosing, and initially it was the Advil, it was the Tylenol, that sort of thing. And then they would use opioids, narcotics for like breakthrough pain. for your cancer patients that are terminal and they're, you know, in pain towards the end, a lot of times that around the clock medication will be your extended release narcotics. And then they'll use the short acting narcotics like your Oxy-IR to deal with the breakthrough pain. So, you know, that's very important when you think about pain management for these patients. All right, let me check a look at the chat here. Does the Huber needle stay in the port or does it come out and leave a catheter? So the Huber needle itself is actually attached to like a very small catheter. I would say maybe like 4 inches. So the Huber needle stays in, it's attached to that catheter, and the nurse is going to get into the port. How they give chemotherapy is by attaching the IV tubing to the end of the catheter. It looks very similar to like a peripheral IV line, except it's shorter and it attaches to this Huber needle. Now the Huber needle stays in place because there's a sterile dressing over top of it. Very similar to like an IV dressing you would have over a peripheral IV. It's a little bit bigger because it covers the entire port site. So as long as the needle is in there, it is considered accessed, okay? Prior to removing the Huber needle, they will put a little bit of heparin in there so it sits inside the port, and then they'll remove the needle. Once a month, just as general maintenance for a port that's not routinely being used, it should be accessed and flushed with heparin. Just to make sure there's not building up blood clots or anything inside the port. But for somebody like Susie, hers is going to be, you know, her port was being used every other week. So for her, it's being, before they would de-access after her chemotherapy treatments, they would put a little bit of heparin in there. Now that heparin didn't go throughout her body. They put a very small amount in there so it stayed inside the port to keep that functioning. Okay. All right, let me go back up. I'm getting a couple more up here. All right, so are we only expected to know the general concepts of cancer? Yeah, the stuff that we talked about is where I really want you to focus on, you know, the staging, the grading. I did have you read a little bit about specific types of cancer, mainly for the health screening, the health promotion piece, you know, what kind of screening tests, and we talked about these, you know, the mammogram, the breast self-exam, the clinical breast exam, you know, your pap smear, you know, your testicular self-exam, the PSA, the digital rectal exam, colonoscopy, the mole patrol, you know. So, and then the reason I had you focus on that is because those are all health promotion and health screening pieces. Because part of what we do as an RN, one of our major roles is education of the patient. So promoting, you know, health screening practices, you know, at appropriate times in the patient's life when they get to certain ages is going to be a critical piece of what we do. Because just as a general principle of cancer, the earlier we catch something, if we diagnose something that is in an early stage and we get that, it should hopefully be easier to treat, and hopefully the patient will have a better prognosis long term. You know, if we're not catching something like colorectal cancer, if we didn't catch it till it was stage 4, it's already causing an obstruction and it's metastasized to the liver and, you know, the other abdominal organs. That's not going to have a good prognosis versus somebody that has a small tumor with very limited spread that's actually just in the colon. So that piece is pretty important, you know, looking at diagnosis and that and how you stage that and the health screening. Okay, what about the cranial nerves, functions of different lobes? I would not get all technical as much on the cranial nerves. What I want you to understand about that is as you're working up a patient who has a neurological dysfunction, they're initially going to do a lot of testing. And what's helpful with the cranial nerves is that can help identify where the problem is. So we talked about stroke symptoms just as a general thing. And we know if it's on the right side of the brain, it's going to affect the left side of the body and vice versa. The other thing you need to consider, and just as a general knowledge, you know, you don't have to get technical with every area of the brain, but understand that wherever the clot is, wherever the bleed is, that where the location is, that's also going to affect what you're going to see. So for example, in my dad's stroke, his bleed was at the thalamic artery. So it's right down by the thalamus, by the hypothalamus. So one of the things he struggles with is actually regulation of body temperature. If you check his body temperature, he generally runs in the high 94s, low 95s, and that is typical for him. But every time he goes to the doctor, they're freaking out because, oh my God, he's running such a low temperature. Well, it's because of the area of the brain that was damaged. He also tends to feel cold. Not that when you touch his skin, he's cold, but he has the perception of being cold all the time. So, you know, it can be 65 degrees outside, which sounds really nice, but if there's any type of wind or breeze, he's shivering. Okay, so I bring that up because other areas of the brain will also kind of dictate what you're going to see with the patient. You know, we always think about the frontal lobe as being the essence of what makes a patient. It really does control personality and behavior. So when you see frontal lobe damage, especially right frontal lobe damage, that's where you really tend to see, sometimes it's even complete personality changes, very impulsive behavior. They don't recognize their deficits, and they'll be the ones, they're major safety risks, them little right-sided strokes, especially if it's up in the frontal lobe. You know, so just kind of understanding that, you know, if it's the left side of your brain, the left side of the brain tends to also control speech. So you'll see more aphasia, expressive and receptive, if it's a left-sided stroke. So just kind of understanding a basic idea of, you know, you have your standard stroke symptoms, but you're also going to see other things based upon the actual location of the damage, the location of the insult. Is it in the scope of practice of an LPN to suction a patient? Yes, it is. They can suction. They can do sterile procedures. You know, again, when we talk about suctioning a patient, it's not just about the task. So for example, if you're talking somebody that, you know, they're a long-term ventilator patient, they require periodic suctioning, that's part of their standard everyday care, that's totally appropriate for an LPN. If we're talking about a patient who's in the ICU and they're having copious secretions, yeah, you can delegate that task, but that particular patient requires additional assessment and intervention from the RN. So remember, just because the task is appropriate doesn't mean the situation is always appropriate. And we've used examples before with vital signs. APs do vital signs all the time. It is not appropriate for me as the RN to delegate vital signs in an unstable patient to an AP. Okay, that would not be appropriate. APs do INO all the time. Okay, well, tabulating output. Well, I would not have them tabulate output in a patient who's receiving a CBI. I would expect them to help me with emptying the Foley and documenting the amount that they emptied. But the actual calculation piece and the ongoing monitoring, that's not in their scope of practice. So remember, you're looking at the task, but you're also looking at the circumstances of, you know, delegating that task. Okay, if that makes sense. All right, let me work my way down the chat box here. What types of cancers would use immunotherapy? So we talked a little bit more about that. Immunotherapy is, you know, it's kind of really come about in the last, I want to say 20 to 25 years, where we're doing more of the gene testing with the cancers. And if we can find, you know, specific antigens on the cancer cells, we can do what we call immune therapy that essentially has antibodies in it that attack those specific antigens. So it's not necessarily what type of cancer, it really is very patient specific. It's not something that we do with all patients. It is something we do, like in a case with Susie nowadays, if she would be diagnosed now, she would have been a great candidate for this because they would have worked up her cancer, actually did the genetic mapping on her specific cancer to be able to hopefully find something that would have been targeted her cancer a little bit better. You know, we're talking 10 years down the road. but immunotherapy at the time, you know, if we had had the capabilities that we have now, probably would have been more beneficial to her, that they could have kind of targeted that. What's nice about the immunotherapy is it's created in a way that it's targeting the cancer cells specifically, because those cancer cells, they're abnormal. So they have certain markers on them that if we could find something that could identify and target those markers, it's going to be very specific to the cancer cells versus, you know, affecting all of the cells and seeing the side effects that we do. So it's something new out on the horizon. Again, not used with every patient, but very beneficial for a lot of them. ATI said chemo patients can eat tart or citrusy foods to decrease the metallic taste in their mouth. So that is something that you will see. A lot of patients will describe how tastes of certain foods will change. It might have a metallic taste. There are some patients, sometimes having a citrus food can decrease that taste, but you have to balance that with the stomatitis that they have. You know, if you have something that's all red and inflamed and just, you know, a hot mess, citrusy foods tend to exacerbate that. So in that case, you kind of have to balance it out. With the stomatitis, they're going to be using that baking soda rinse like we talked about. If they're using the magic mouthwash before meals, they can have the citrusy foods. It would be very important to rinse with the baking soda afterwards. But if eating that, here's the bottom line. At this point, this patient is going to be malnourished. So we want to get calories in them. And if that's the only thing that they're going to be able to eat, then we work with that. You know, a lot of times what we're doing is choosing the lesser of two evils. And really having to balance it out. So you can see how, you know, when you talk about chemotherapy, it is just like the perfect storm, because we cause all this inflammation. And if you stop and think about, well, why do we see the side effects that we do? The side effects are caused because the chemotherapy is attacking healthy cells. And think about what types of healthy cells are they attacking the most? Cells that have a rapid turnover. When you eat, even if you're not receiving chemotherapy, just you eating your lunch, okay, our mouth, our entire GI tract is exposed to all sorts of foods, chemicals, everything, preservatives in food, 24/7, 7 days a week, 365 days a year. Okay, so those cells, because they are essentially subjected to stuff every single day, they have a very rapid turnover rate. And that is why your GI cells are affected significantly with chemotherapy. Same thing with your blood cells, your bone marrow. Okay, platelets have a life cycle of 5 to 7 days. Okay, white blood cells have a life cycle of 10 to 14 days. Your red blood cells, you're looking at 90 to 120 days. So you have a very rapid turnover. Those things are being made every single day. And that's why they're affected by the chemotherapy. So, you know, in this case, yeah, they're going to have the stomatitis. The chemotherapy does change the metallic taste. You know, we're trying to balance that. If the only thing they're willing to eat and tolerate is citrusy foods, okay, I want to get some nutrition in them. Let's up the baking soda rinses. They might need to be doing it every 2 hours during the day, you know, to help with that. Again, using that magic mouthwash, we're trying to maximize their intake because their body needs the building blocks literally to be able to survive the treatment that we're giving them to destroy the cancer. All right, if a patient has a right-sided stroke, would they have poor judgment and the loss of depth perception with weakness, or symptoms of a stroke on the left side? I'm not quite sure exactly what you're asking, but I'll just kind of go with what I think, and you can clarify it then if you need. So a right-sided stroke, you're going to see the weakness, the paralysis on the left side of the body. So let's just make sure you're differentiating this. When I say right-sided stroke, I'm talking right head, okay, on the right side of the brain. I'm going to see the symptoms, the weakness in that on the opposite side. Okay, I'm going to see the weakness, the paralysis on the left side. When you think about your right brain, you tend to have, that's really where you get a lot of your behavior, your impulse control, your judgment. So those people may have problems with like abstract thought. They might slur their words, but not because they don't know the words. They're slurring them because of the muscle weakness of the mouth muscles and the tongue muscles that they use to create speech, okay? Versus a left-sided stroke, a left brain stroke, you're going to see the weakness on the right side, but because the left side of your brain it contains your language center, those patients will tend to have problems with expressive and receptive aphasia because they're not processing things very well, okay? So you can have a little bit of that on the right side, but you see it more pronounced with your left-sided strokes. So they're the ones that really tend to have the problems with, you know, finding the words, speaking the words, and then even understanding and, you know, being able to process what is being said to them, okay? So I'm hoping that answered your question with that, I hope. Other things to keep in mind with your strokes, remember the headache, that sudden onset headache, that's very indicative of your hemorrhagic stroke versus your ischemic. Also, the projectile vomiting is associated with increased intracranial pressure, which you tend to see more with your hemorrhagic stroke. So while they're listed as stroke symptoms for either, you are more likely to see those with hemorrhagic strokes. Okay, what other questions do you have? It's a free-for-all, you can ask anything. All right, if not, I'm going to kind of move on here for a second. Can you open the ATI? It should be open, the ATI practice exam. The ATI practice exam does have a 24-hour lockout between attempts. Is that what you're talking about? Can I remove the lockout? I think that might be what you mean. I'm not sure. If so, just kind of let me know if that's what oh, for additional attempts. Yes, I can do that. I can do that. All right, so my screen sharing is paused. Hold on a minute. Let me get situated here. And then I will go back over this. So I want to kind of just briefly go over this grading thing. Okay, all right, screen sharing is paused. Resume share. Maybe not. Okay, hold on. There we go. Can everybody see my screen now? It should be the PowerPoint that was there. You can just kind of type in yes in the chat box if you can. I'd appreciate that. Oh, here, one more question. Why do patients with intracranial pressure have bradycardia and hypertension? So what happens, oh, you guys still see the worksheet. Okay, I'll fix that. Just give me a minute. So with the increased intracranial pressure, you have a couple things in play here. As the pressure increases, because of the skull, it has nowhere to go. Let me stop the share here. The swelling, as the brain swells, it has no place to go. So it's actually going to push down and swell in on itself and push down towards the brainstem. As you're doing that, remember, down in the brainstem is what controls your breathing. It also controls your heart rate. So the blood pressure will go up because your body is going to try to, it wants to make sure the brain is being perfused. Unfortunately, in raising the blood pressure will continue to raise the pressure, and then you have the brain essentially herniating down on itself, down on, you know, that brain stem. And because of the pressure on the brain stem, that's what causes the bradycardia. So you'll talk a lot more about that next semester and the following semester in MedSurg 2 and MedSurg 3. You know, for the time being, I just want you to understand that when you have damage to the brain from a stroke, it is going to cause some swelling. You do see that with the ischemic stroke, but the swelling with an ischemic stroke tends not to be as pronounced as what you're going to have with the hemorrhagic stroke. With your hemorrhagic stroke, that's one of the reasons why we sedate them right away. That blood that hemorrhaged out into the brain tissue will be reabsorbed. It is going to get reabsorbed into the circulation. But what we want to do by sedating them and putting them on the vent is we don't want to cause any more increase in pressure in the brain than is already there. If the numbers go up, and they do have increased intracranial pressure. There's a couple things we can do. We talked about positioning. You never want the head of the bed above like 15 to 20 degrees. That help, and keeping their neck straight so they have that nice outflow. There's also medications that we can give to help reduce intracranial pressure. There's a special type of diuretic. It's called an osmotic diuretic, mannitol, that we can use. We also give a very specific corticosteroid, dexamethasone, Decadron, that helps reduce the swelling in the brain. In severe cases, they can actually do what they call a ventriculostomy. So they will actually drill a hole into the skull and insert a catheter, and they can actually tap off some of that excess cerebrospinal fluid to help relieve the pressure. They can also do that and use a monitoring device, so you actually get, you know, an internal ICP reading. So just kind of talking through that. But you'll get more on that in like MedSurg 2, MedSurg 3. Right now, I just want you to have kind of a basic understanding of it and understand that your hemorrhagic stroke patients are going to be at very high risk for developing that increased intracranial pressure. And that's why we do the treatment that we do. That bleed, you know, we want to control the bleeding, we want to control the blood pressure, but your body on its own is going to plug up that bleed. That's what it does. But that's also why it is critical to do that non-contrast CT to determine, are we talking about a hemorrhagic stroke or an ischemic stroke? Because just think about this for a second. If it's a hemorrhagic stroke, the body's trying to fix it. The body's trying to plug up the leak. If we didn't know it was a hemorrhagic stroke and that person was given TPA, a clot buster, that TPA is going to eat away at that new clot that the body put there to stop the bleeding, and your patient's going to hemorrhage into their brain. So that's why that's, you know, so critical. All right, so I'm going to go back to sharing my screen. This time I'm going to pick a different screen, and hopefully this will work. All right, now do you see the PowerPoint? I'm hoping. I'm hoping. Good. All right, so I'm going to kind of go through this. If you have the worksheet, the actual worksheet there, it's kind of helpful, and you can actually do this with your own grades. Now, you do have to keep in mind, you haven't taken the Unit 6 exam yet, so, but we'll talk about that when we get to that slide, that you can kind of, you know, guesstimate right now. But then tomorrow, after you have a solid number for your Unit 6 exam, you can actually go through and you can get very specific numbers and know exactly what you need on the final to, you know, to pass Tier 1, all that. So let me start off by saying you probably all are in much better shape than you think. And that's why I do this worksheet, because of the way things are weighted. It's very complicated to calculate if you're not used to doing it this way. So just very briefly, Tier 1, Tier 2, you guys know about that. For you, you got to press Tier 1 first before we go to Tier 2. So right now you're focusing on Tier 1. 3 components. You have your unit exam average. That's going to be 65%. Your quiz average is going to be 20%. And then your exam score, your comprehensive final exam score, is the 15%. So when we start with your unit exams, so if you were to open your Plato right now and you looked at your grades in the grade book, it's going to start off with the unit exams, and it's going to list, you know, the unit 1, 2 exam, 3, 4, and 5. But above that, it's going to have something that says, like down here, it'll say unit exams, and it'll come over and it's going to give you a number out of 65. And that is because the unit exams are weighted at 65%. Okay. So that's already there for you. If you took your unit exam grades, and right now you have 4 exam grades, because it was a combo for 1 and 2. You had unit 3, unit 4, and unit 5. So if you took your 4 grades that you had right now and just average them, add them up together, divide it by 4, that's going to be your exam average. Okay, if you did that, it would be the same number as if you took, down here as the example, it's 55.4125 divided by 65. If you did that, you're going to get the same exact exam average. Okay, but it's a nice way to kind of check Plato. So in box A, when you're doing this, okay, you want to take your exam average, So go ahead and average those and then multiply it by 0.65. And in this case, for this student, it's 55.4125. You're going to put that in box A. This should match what you have on Plato. Okay. Now, tomorrow, after your Unit 6 exam is posted, this number will recalculate because it's going to have all 5 unit exam grades there. Okay. But you can also do it manually. You can add up your 5 exam grades, divide it by 5 to get the average, take that average, times it by 0.65, and you'll get that number. That number should match what you have in Plato. Okay. So once you take the exam tomorrow, that's going to, solidify all that. Okay. The next piece is your quizzes. Now, we had 32 quizzes this semester. I did go through today. If you were finished with all 4 of the Prep U quizzes for Unit 6, I went ahead and posted that. If you weren't, that's okay. They're not due till tomorrow, till 12. I just left yours blank. Okay, so if you're done with Prep U, if you scroll down everything in your grade book, as long as you have a score for all of your quizzes, that is going to be final. If your very last one is blank, it's because you're not done with the Prep U yet. As long as you finish your Prep U tomorrow by noon when it's due, that's going to plug in as a 100. There were 4 Prep U's this unit. They're each worth 25%. So if you finish 3 out of the 4, it'll be a 75. If you finish 2 out of the 4, it'll be a 50, and so on and so forth. But once you have all of those quiz averages in, if you want to, you can add up all 32 of them, get a big number and divide it by 32. That's going to be your quiz average. Okay. Again, Plato already calculates that for you. It will say quizzes, and it will be a number out of 20 because that's 20% of your final grade. So for this particular student, it was 18.75. Okay. If you have questions as we're going, you can put them in the chat box. Okay. So moving on, because we have 3 pieces to tier 1. So you'll have your unit exam average and you'll have your quiz average. So you take those points, okay, from your box A, which was the weighted points from your unit exams, plus your weighted points from your quizzes, and you add those together. You can throw them in box C. For this particular student example, the student was doing fairly well. They actually already have 74.125 weighted points. So this is a pretty good shape here. Okay, now, because the minimum score you have to meet a 75 for tier 1, 75 weighted points. So we're going to take what is needed, which is 75 weighted points, and this particular student already earned 74.1625 weighted points from the exams and the quizzes. Okay. So what the student needs is 0.8375 total weighted points. And that's all fine and dandy, but you're asking, but what does that mean on the final? And that's where we're going to get you. So that's the weighted points that they need. Okay. So now you're going to I'm going to actually skip ahead. You're going to go ahead and do algebraic principles. So because the final is 15%, which is 0.15, here are the weighted points that this student still needed, okay? And my final exam score is unknown. We don't know. We need to figure out what we need in order to pass. So you have this times this equals 0.8375. So if you're following basic algebraic principles, I got to get rid of this 0.15. So to do that, I'm going to divide both sides by 0.15. So when I do that calculation, it ends up being 5.5833, but you need the whole number. So regardless, this always rounds up. So here, this particular student needs a 6% on the final to pass tier 1. Okay. Now, I would be very willing to bet that when you guys do your math, you are going to be shocked at the score you need to pass this class, because many of you are going to look at it and go, oh, that's not real. It's probably going to be in the 50s or 60s. Okay. Now, that does not mean you blow off my final. Okay. Please do not blow off the final. This just is to get you to tier 2. All right. When you get to tier 2 generally benefits students because your clinical portfolio gets added in, and that gets factored in at 20% of the overall course grade, which is pretty significant. As I was going down looking at your overall clinical portfolio scores, the majority of you are sitting at solid Bs. So you will likely see, you know, a tier 2 grade. The majority of you, I think I'm going to have a lot of Bs this semester. I'm going to have a couple As. I think most of you are going to be Bs. Okay. Looking at that. So any questions on tier 1 before I move to tier 2? I know it's pretty complicated. So sometimes it's helpful to have, you know, the PowerPoint open, the worksheet, if you print it out, and actually have on your phone where you can access your Plato gradebook. So you can plug the numbers in right as you go. Okay. I don't see any questions thus far, so we're going to keep going. All right. So for tier 2, as long as you hit 75 on tier 1, you're moving on to tier 2. Tier 2, essentially, we're just adding in the clinical portfolio. So in order to make room for the clinical portfolio, the exam average is worth a little less, the quizzes are worth a little less, and your final exam is worth a little less to make room for the portfolio. So that tends to be very beneficial to the students. So you're going to use the same thing. You had the average way back of your test average. Okay. So instead of it being 65%, now it's going to be 55%. So you're going to take that average. And I think if I go back, let me just go back a second. This student's test average, oh, I didn't even put it in there. But anyway, it would have been, you would figure it out. It's this number divided by that number. So whatever the test average is, you have the test average, and then you're going to multiply it by 0.55 and stick the result in the box. Don't do any rounding. Keep all your decimal places as is. You don't round till the end. You're going to do the same thing with the quizzes. What was the quiz average? And then instead of multiplying it by 0.2 like you did on page 1, now it's only worth 15%. So you're going to take that quiz average and multiply it by 0.15. Stick it in there. Your clinical portfolio, if you go into the clinical Plato site and you look at your grade book, at the very top, it'll say final calculated grade. Okay, that is your overall final calculated clinical portfolio grade. It'll be a number out of 100. Okay, so you put that in there. You're going to take that number. So in this case, the student had an overall 94.2% for a final calculated portfolio grade. I'm going to take that 94.2 and I'm going to multiply it by 0.2. Okay, so I'll have box E, F, and G. So the E is the weighted points from the exams on tier 2. Box F is the weighted points from the quizzes on tier 2. And box G is your weighted points from your portfolio. So you would add all those up. So actually, I put them in here. I didn't put them in the other part. So here, for this particular student, the exam average ended up being 85.25%. I multiplied that by 0.55. So this is where I get my weighted points. Okay. Same thing, my quiz average, 93.75%, multiplied by 0.15. This is where I get my weighted quiz points. And the same thing for your portfolio, the 94.2 times your 0.2, that's where I get my weighted portfolio points. When I add all those together, 79.79. So this student literally, you know, has already passed, okay? So to figure out what you would need, you can figure out a C, a B, and an A. For this student, okay, to get enough weighted points on tier 2, it's actually a negative number, okay? But if you go back to tier 1, remember you have to pass tier 1 to even get to tier 2. So even though tier 2 says it's a negative number, she still has to pass tier 1. So this student has to score at least a 6% on the exam. And by the way, this is actually one of your classmates. So if you recognize this as you, don't blow off my final. You can still do really well. Okay, don't blow it off. You're going to do, so here in this case, the student needed a negative to get the C, but again, we still needed the 6% on tier 1 to get there. Now, I'm sure this student does not just want to pass with a C, okay? So you can actually figure out what you would need for a B and for an A, okay? So basically what you would do, instead of taking 75 minus that total, you're going to go to 80 and then you're going to go to 90. So this equals the weighted points that you would need, and then you're going to follow the same protocol. So now instead of it being the 0.15, it's 0.1 because this is tier 2. So for a B, here's your weighted points. So to score an overall grade of B, the student has to get a 21% on the final exam. Pretty easy to do, okay? Now wait, this isn't right. What did I do here? I don't know, something's not right here. I think I made a typo. The second one would be 112%. That should say to earn an overall course grade, it's an 112%, I think. I'll have to double check on that. But you're gonna use the same process with that, okay? At the very end, your final tier 2 grade, this is the grading scale. So when you calculate the final tier 2, that's gonna be what your overall course grade is gonna be, and that is what would be posted in SIS as your final course grade. Now, I am gonna tell you this because there's about 10 of you that have not done this yet. You must upload your final summative clinical evaluation to Typhon. So if you have not done that, you need to go into the clinical Plato, look at the instructions, download it, sign and date it, add whatever comments you want, and upload it to Typhon, because otherwise your grade's going to be posted as an I, incomplete. And I would prefer not to do that because that makes more paperwork for me. So if you haven't done that, you need to do that, okay? But that is how things work for the grading. So hopefully that was helpful in showing that to you. If you have questions on that, I'm happy to, kind of help you through that. Again, everything's kind of a little in flux because you haven't taken Unit 6, but the reality is, just as a basic way to think about it, your unit exam average right now is based on the previous exams. So if your exam average overall is 76%, as long as you score at least a 76%, it's not going to go down, okay? If you score higher than that, your overall exam average is going to go up. If you score lower than that, it's going to go down. So as a rule of thumb, if you're looking at it, go ahead and look at what your exam average is. As long as you score that amount, it's going to stay the same. It's not going to significantly alter, okay? If you would score significantly higher, obviously the better you do on Unit 6, the less points you're going to need on the final. And vice versa. If you don't do as well on Unit 6, then the points and the score you need on the final is going to be higher. So I put this out here for you just to kind of work it through so you can sort of see where you're at, because when I have a weighted system like this, it's not very easy to understand, and a lot of students without the worksheet would go into the final thinking they need like an 82 or a 78, when the reality is the score that you actually need just to pass the class it tends to be a lot lower than you would think, okay? And it's the way things are factored in. So if you have any additional questions, you can throw them in the chat box. Again, you can work up the numbers, that's fine. Again, work them up after you get your score tomorrow, because then that's very solid. You'll know exactly what you need on the final in order to pass the course. You can figure out tier 2 for C, B, A, and you can kind of, work that through. So, all right, I don't see any other questions, so I am going to go ahead and stop here. And just a push, I am having that exam review prep session tomorrow at 11 o'clock via Zoom. The exam will be available for access at noon. So I will hopefully see you then. Take care.